as she comes today to present on Stanford's Better Choices, Better Health Chronic Disease Self-Management Program.
Thank you. Does that work?
There you go.
Okay. Thank you so much for having me. I am so excited to be here. And, you know, I think nurses are the absolutely best people on the whole planet, so I think you should all give yourselves a little round of applause for choosing the profession that you have. And I've got quite a few slides here, so I'm going to go cruising through them. Okay. I just need a little longer arm. Maybe I'll do this. So why am I here today talking about this topic? And I've asked myself that many times over the past few years because I don't get the disconnect that we're experiencing. And so I hope that by the end of this short session that you'll be able to think differently about why people are readmitted to the hospital as frequently as they are. Almost 20% within a 30-day period of time from discharge are readmitted. And what's that all about? And what's this patient-centered medical home, this patient-centered medical model all about that we're beginning to hear so much about? And what about the role of the nurse and care management and case management and the role of self-management as chronic diseases are increasing so much across our country these days? As was mentioned, I've been working for the last 2.5 years primarily with primary care providers and specialists, dialysis centers, patients, their families, community organizations, in looking at diabetes and chronic kidney disease and how that in and of itself is such a risk factor for cardiovascular events and why care transitions between these levels of care are so complicated that people just don't even know what doctor or nurse to call when they're having episodes or incidents, and so they end up in the emergency room and then admitted to the hospital. So why are things so complicated? It's because as our country is aging and as our technology has improved, we are living a lot longer and we have a much more complicated healthcare system and treatment system than we had when I got out of nursing school. So if we just start to look at the arc of just the cardiometabolic syndrome and how our lifestyle in this country basically promotes disease progression. We use too much salt, we don't get enough exercise, we're still working on smoking cessation, and then there are some factors that are just inherent, genetics and age. But really, there's a lot we could do within our own culture if we started thinking a culture of health instead of a culture of disease. So why is this such an important thing to Medicare? Because of the cost, because patients aren't getting the care at the right time, in the right setting, when they need it, where they need it, isn't happening right now. And as the complications of diabetes increase, then the cost increases. And as our country continues to be living a culture of not promoting health, then we continue to create this tsunami, basically, of diabetes in the United States. And what does that do? It leads to these complications, which lead to unnecessary decreasing the quality of life for individuals and their families, and not just the cost. It's the right thing for us to do to start to educate people on there are ways that they can know their bodies, know why they're taking the medications that they're taking, know why the tests need to be done, so that they can start self-engaging in promoting their own health. There's a real disconnect between communication of the various levels of care. So an individual who may be at home may end up one day seeing the primary care provider and the next day ending up in the emergency room, and it could even be that that very next day the dialysis center, if this is an individual who was not ever tested for chronic kidney disease. And it's really not uncommon. I hear about it all the time where this is truly what's happening in Montana. An individual will end up in the emergency department because they're not feeling well and literally the next day have to start dialysis. I remember a case manager from one town here in Montana not long ago telling me how devastating it was when she found out that the patient that she was supposedly helping, she had decided that she wasn't going to have her blood pressure taken anymore. And she got away with, well, do we wonder why she wasn't going to have her blood pressure taken anymore? Probably she got told it was high. She didn't want to deal with it. So how many years it took from when she decided to never have it taken again until she ended up on dialysis, only she knows. But those are real stories of real patients. At Mountain Pacific, we've been working with some new software that we can look at Medicare billing information, and we can look at any community or we can look at the entire state, and we can see when somebody is discharged from a hospital and if they go to a nursing home or if they go home health or if they just go home. And then how many people get sent back from the nursing home or the home health agency or home to the hospital because they didn't have the appropriate follow-up post-discharge that they needed. So all of that being said, think about when somebody's in the hospital and they're about to be discharged. And we as nurses, we are teaching them exactly what they need to do when they get home, and this is your medications, and they're stressed. They maybe don't even have any kind of support once they get home. And so they're not really hearing what we're saying. And then, on top of that, what they did hear, you probably heard about half of it or remembered it incorrectly. So we wonder why when people get home, things fall apart so quickly. The majority of the readmissions that happen within the first 3 to 4 days. 63% of those are because of a medication issue. People go home, they've got their new medications, they've got their pill box all set up with their old medications, they add their new ones to it. Oh, forgot about the fact that I was supposed to pull some of these out. So we really are going to have to start to look at how can we build within our culture some medication reconciliation at the various levels of transfer of care. And it involves everybody. It involves entire communities thinking about how do we make this happen. Because we're not just a medical community and then a social community and then our little family group that lives within that community. We are a community. And if we look at this from a patient-centered perspective, how big is the community? Well, it really depends on me as the patient and what's going on with me. So if I'm in Shelby, Montana, and I've got something going on and I need to go in and get an antibiotic, my community is probably just Shelby. But if all of a sudden I've got a cardiac event and I need to be in Great Falls or Missoula or Billings, then all of a sudden my community becomes a whole lot larger. And what then if I have complications and I have to be flown to Seattle or somewhere? Then my community is even larger. So when we're putting patients first, patient-centered care, it means that there is a primary care provider somewhere that each of us connects with, and that it's our job to keep that individual informed of these various levels of care. So how do we do this as a community? Well, like I said, we don't do it alone. We don't operate in silos. There has to be communication across, not just from the specialist to the primary care provider, but from the hospital to the nursing home or the home health agency and back. And primarily, always, the patient has to have the appropriate information and have heard it at such a level that they understand what's going on with them and what is so important that they need to convey when they transition to the next level of care. It takes leadership commitment. And by that I mean the community services that are available as a safety net support out in the community. It means the senior citizen centers. It means the leaders of the hospitals and clinics. and nursing homes and home health agencies and case management teams. It means all of us as families and caregivers and friends really starting to look at our community and what we do to improve the health of our community. So with all of that being said, how often do you think we really engage in our own management of our health care? Stanford University has been doing studies for quite some time on the project Better Health, Better Choices, Better Health. And I was fortunate enough to be able to take this training a few weeks ago. And it was really mind-opening for me as from a nursing perspective. And I'm a hospice nurse, and I did this years ago. And I'd write things out for people, and they would tell me, yes, I know I'm going to call you if I get a temperature of 102, and yes, I know this is going to happen, and yes, I know that's going to happen. And yet I've been working with my father with some of his health care issues lately, and it's, of course, a remote connection, and I've traveled and gone with him to his specialty appointments, and what I realized was my dad didn't feel empowered to ask his doctor questions. And he didn't even really know what to ask. And they would give him a new medication or they would order a new test. And so he'd be kind of fussing about it, but decide that he probably should do it. And as we worked and I started explaining some of these things to him, he started realizing that he could ask those questions. Or he could say, I'm not going to do that. And then the doctor could offer maybe some other choice that he would comply with, and he could have better health. And fortunately, he's doing great. In fact, I heard he just got out on the tractor the other day. But it really is each of us recognizing that we as individuals are the specialist in our own health and our own body. So chronic disease is on the rise, and why is that? Well, I'm thinking from my perspective that it's probably because we're ignoring what's going on with our bodies. So the word chronic, and that means it's been around for a while, right? Well, why then do we become shocked when we all of a sudden go to a doctor's appointment and we end up coming out being coined, now I have a chronic disease? Well, it's not new, I've had it. It's just, I didn't recognize it, I didn't want to deal with it, I didn't want to deal with the symptoms. So we're disease oriented and we're trying to ignore disease instead of flipping the coin and being health oriented and doing everything we can to engage ourselves in being health oriented. Oops, wrong direction. So there's one thing that the Stanford, well, there's a lot of evidence-based information out there on the Stanford Project, and you can go out to their website and get all kinds of information. One of the things that they've really discovered is that no matter what the chronic condition is, people with a chronic health condition have certain things in common, and they can really help each other learn how to self-manage by not focusing on their specific disease, but by focusing on their individual lives, their beings, their families, what they like as activities, and helping each other to see the healthy side of life rather than being focused on the disease side of life. So I like this definition a lot. Self-management involves the person with the chronic disease engaging in activities that protect and promote health, monitoring, and managing of symptoms and signs of illness, managing the impacts of illness on functioning, emotions, and interpersonal relationships, and adhering to treatment. So what patients are saying is that going through some kind of self-management training, and it doesn't have to be this specific model, the very thought of first taking the first baby step towards self-management. If some of you stopped by